Welcome back to this next video in which we are studying headaches. Okay, so we're now going to return back to discussing the pathophysiology of tension-type headaches. So let me just remind you about this type of headache because it was quite a while ago since we actually talked about the actual headache. And I also want to just add a little piece of information on here that I forgot when I was giving you the basic information about this type of headache previously. So, remember, tension-type headaches are also called stress headaches, and they are the most common type of headache. Most people will suffer from a few of these every year. This is the type of headache that is usually in the temporal regions of the head, and it feels like squeezing, and if it extends into the frontal regions and the occipital regions, then it can be described as feeling like there is a band around your head. The severity is not particularly severe, it's mild to moderate, and it is triggered by things like emotional stress. So when you've had a very stressful day and you then get a headache, this is the type of headache you've got. It's also triggered by things like fasting or sleep deprivation, and it's the type of headache that you get as a systemic symptom of inflammation. So when you have a cold, or when you have the flu, or when you have a tummy bug and you get an accompanying headache, that type of headache is a tension type headache. Accompanying symptoms that can accompany the headache, you can get nausea and vomiting. However, those are symptoms that can accompany any type of headache, and we'll discuss the basis behind that in this video. Additionally, what can happen is you can get cutaneous allodynia. So if you suffer from very frequent tension type headaches, for instance, if you suffer from chronic tension type headaches, and remember the definition of chronic tension type headaches is that on greater than or equal to 15 days in a single month, you get a tension type headache. Then we say that you're suffering from chronic tension type headaches. Most people don't have chronic tension type headaches. This is a very serious problem. Most people just suffer from episodic tension type headaches, and they don't seek medical help for that because it's perfectly normal. Right, but if you suffer from very frequent tension type headaches, then what can actually occur is something called cutaneous allodynia, which is when you're not suffering from a headache. Between headaches, the regions that hurt in your headache, for instance the temporal regions or the forehead regions or the occipital regions, these actually hurt if you just touch them. So stimuli that should not cause pain are causing pain. That's what's meant by this word called allodynia. It means that stimuli that shouldn't cause pain are causing pain. Right. So, the piece of information that I didn't previously give you, but now which I want to add on to here, is how long do tension-type headaches usually last? Now, hopefully, just from common experience, from normal experience, you're aware of how long these can last. It's extremely variable, so they can last anywhere from between a few minutes, to days. So for instance, if you've got it as a systemic symptom of inflammation, then it can last for days, this type of headache, because the flu, for instance, can last for days, and that headache that's accompanying it can therefore last for days. So the timing is a few minutes to days, and you really can see now the difference in the size of the pens. I've gone over to using the slightly thicker pen, and this was my original short, thinner pen. Okay, so that's if you're wondering why the text is a different size. So, the timing for tension-type headaches is from a few minutes to days. Okay, so let's now try and understand the pathophysiology underlying this type of headache. So, we want to now understand how these triggers can actually give rise to the pain. So, we have said that we believe that the pain in a tension-type headache arises in the muscle tissue, specifically in the temporalis muscles, the frontalis muscles, and the occipitalis muscles. And I've now spent an incredibly long time explaining to you exactly how the primary nociceptive afferents with the nociceptors that innervate those muscle tissues are going to get into the central nervous system, and how they're going to relay their information up to the contralateral primary somatosensory cortex. Remember, it involves these trigeminocervical complexes. So you have two of those, a left trigeminocervical complex and a right trigeminocervical complex. For the left frontalis, temporalis, and occipitalis muscles, the primary nociceptive afferents will go into the left trigeminal cervical complex, where they'll synapse on a second order nociceptive neuron, which will then cross over and ascend to the contralateral ventroposterior thalamic nucleus, either the ventroposterolateral or ventroposteromedial, depending on whether it's the trigeminothalamic tract or the spinothalamic tract, and then it will go up with a third order neuron to the right primary somatosensory cortex, and the exact opposite for the right hand side. Okay, so we understand the anatomy by how the activation of the primary nociceptive afferents can be relayed up to contralateral primary somatosensory cortex. What we don't understand yet is how these triggers can actually activate the nociceptors at all in those muscle tissues, and that's what I'm now going to turn my attention onto. And I'm afraid the answer is not particularly satisfying. It's not well understood at all. The best understood example is as a systemic symptom of inflammation. So I'm going to talk about what we think, and it is very tenuous. It may well be completely wrong. This is a theory, and it may well turn out that it's the wrong theory. But at the moment, what we think, I'm going to go over what we think occurs when you get inflammation occurring somewhere in the body, and how that actually gives rise to this activation of the nociceptors in the temporalis, frontalis, and occipitalis muscles. And then I will discuss these other triggers briefly. Okay, right. So let's do this then. So, inflammation. Remember, inflammation is something that occurs when you've got an infection, hopefully. Of course, there are examples of diseases where inflammation goes wrong and that causes a big problem, and it's not attacking an infection at all, it's just attacking your own tissue. Those are, of course, autoimmune diseases, but ideally, inflammation should only occur in response to an infection, and the whole idea behind it is we have some sort of pathogen infecting our tissues, we need that gone because it's going to damage our tissues and potentially lead to us dying, so we need troops to come in and destroy this, and all of the troops are in the blood, and the two types of troops are we have white blood cells and we have proteins in the blood that can attack pathogens, the major example being the complement proteins. So when you have a pathogen in a tissue, you need the inflammatory response to occur, and the inflammatory response is the response of the microvasculature, the tiny blood vessels in a tissue, where they change their behavior and start recruiting white blood cells into that tissue, and also they allow proteins and fluid from the blood to come into the tissue, so you form an exudate. What makes the blood vessels undergo the inflammatory response, what makes them do this, it's that the tissue that has the pathogen infecting it, it recognizes the presence of the pathogen, and you start to produce loads of proteins and other molecules, loads of inflammatory mediators, loads of molecules that would not normally be in the tissue fluid that tell the microvasculature what to do. So there are loads of signaling molecules that are released at a site where there is an infection to trigger inflammation. And these are known as the pro-inflammatory mediators. Right, so when you have inflammation going on in a site, loads of these pro-inflammatory mediators are produced to actually produce that inflammation. And some of these pro-inflammatory mediators will end up going into the bloodstream, and these are the ones that give rise to the systemic symptoms of inflammation. So, let me give you some examples then of pro-inflammatory mediators. The incredibly famous ones are the ones I'm going to give you. So, where should I just write this down? So, I'll put this underneath the title of inflammation here. So, famous pro-inflammatory mediators. So, the first two are the most famous, the ones that if you're not going to learn any others, these are the ones you must learn. So IL-1, which stands for interleukin-1. Very, very important pro-inflammatory mediator. It's released at sites where there is an infection, and it is a major cause of inflammation. If you chuck interleukin-1 into some tissue, it will cause inflammation there. Very, very powerful signaling molecule. Another very, very important one, the second most important one after interleukin-1. In fact, I wouldn't really rank them separately. They go together. They're together the most important ones, is tumour necrosis factor alpha, TNF-alpha. So this is tumour necrosis. Oh, damn, I won't be able to fit it in. Necrosis factor alpha. So this is another very important pro-inflammatory mediator. These two together are the major causes of inflammation. So when you've got a tissue that has a pathogen present, the cells of that tissue produce interleukin-1 and TNF-alpha once they've recognized the pathogen. And usually in the tissue there are special cells known as sentinel cells, such as dendritic cells and resident macrophages and mast cells that are specifically there to look out for pathogens. They're specifically there to detect the presence of pathogens, and if they find them, they'll produce these pro-inflammatory mediators. These two are the most important ones. Interleukin-1, TNF-alpha, they cause inflammation, they cause the inflammatory response. Another pro-inflammatory mediator that's not as important for actually causing the inflammation, but is very important with regards to systemic symptoms of inflammation, is interleukin-6. And I suppose I don't really need to write out its name in full because you've already seen how to spell interleukin from interleukin-1, but I'll just do it anyway. I've started it now. Okay, so these are the three I want you to know the names of. Interleukin-1 and TNF-alpha are the two most important ones, full stop. If you don't know anything about inflammation, you must know their names. Forever must their names be revered. They're very, very important. Interleukin-6 is then another one that's good to know. It's very important with regards to systemic symptoms. All three of these, however, are very important with regards to systemic symptoms. So here are three very important pro-inflammatory mediators. When you've got inflammation going on in the site, and it's sort of infections that people commonly get are colds, the flu, or tummy bugs, and we've been over the causes of these. Remember, colds and flu are respiratory system infections. The lining of the respiratory tract becomes infected. The infection usually starts in the nasal cavity, then it works its way downwards. It will go into the nasopharynx. It can't infect the oropharynx or the laryngopharynx because it's the wrong type of epithelium, but then it can infect the lower portion of the larynx, it can infect the trachea, it can infect the airways, and it can infect the alveoli as well. Thankfully, it doesn't usually get that far, neither of them do, flu or colds. Because the immune system comes in and beats it out usually, but it does usually get down the trachea and it can go into the early bronchi if in a bad episode of a cold or the flu. So colds are generally caused by rhinoviruses or coronaviruses, flu is generally caused by influenza viruses, and the infection in the respiratory system gives rise to the respiratory symptoms such as a runny nose, nasal congestion, sneezing, a sore throat, a hoarse voice, coughing up phlegm, all of those symptoms. They are the respiratory local symptoms, and the release of inflammatory mediators into the blood is what gives rise to the systemic symptoms. In a tummy bug, the general culprit for that, there are loads of different culprits for gastroenteritis, but the general culprit that people are most likely to get is norovirus, and that will give rise to, again, local symptoms such as tummy pain and nausea and vomiting potentially or diarrhea, but it will also give rise to systemic symptoms because the inflammation will release these inflammatory mediators into the bloodstream. So what are the systemic symptoms? Well, the systemic symptoms are things like a fever. So these go up to the brain and they cause it to raise the set point for body temperature. So body temperature goes up and you get a fever. They're things like you feel very tired when you're ill. You don't feel good. You feel angry and irritable usually. That's known as malaise. So fatigue and malaise. You lose your appetite loss. These are caused by these mediators. And then other important systemic symptoms are you can end up with muscle aches and also a tension type headache. Particularly, remember the last time you had flu and your entire body ached, muscles all over your legs and your arms ached and you had a tension type headache. Those are systemic symptoms of inflammation. So let me just write a few of these down. I'll guess another colour. So we'll go for green. So the systemic symptoms of inflammation that I'm very, very interested in, I'm not going to write down fever or fatigue or malaise or appetite loss, but the two that I'm very interested in are muscle aches and the fact that you get a tension type headache. And the astute ones among you might realise that potentially the theory that I'm about to tell you might link these two together, given what I've told you about where we believe the origin of the pain in a tension type headache actually is. Okay, the systemic symptoms of flu are generally much worse than the systemic symptoms of a cold. That's what clinically differentiates these. The way we tell the difference between a cold and flu is that with flu you get much worse systemic symptoms. Colds, you don't generally get a bad fever, you don't feel as tired, you don't feel as run down, and you don't get the muscle aches and the tension type headache and the worse, as bad as they are in flu. That's the difference between cold and a flu clinically. That flu has much worse systemic symptoms of inflammation, whereas cold just has the respiratory symptoms and maybe some mild systemic symptoms. But usually if someone has a cold, they can still continue going about their normal activities of life, whereas if they've got flu, they're bedbound. And again, tummy bugs, depending on how severe it is, you can get differing levels of systemic symptoms. Obviously, it's the case that the more inflammation you get, the worse systemic symptoms you get. And the reason that you get so much more inflammation in flu compared to a cold, I don't know if I told you this right back when I first wrote this down, but the reason you get so much worse symptoms, systemic symptoms with flu, is because you get much more inflammation. And the reason for that is that the flu virus, influenza viruses, they are not as nice to the cells that they infect. So these are all caused by viruses. Viruses are intracellular parasites. They go inside cells, they use the cell to make loads more viruses, and then the new viruses leave the cell. The viruses that cause colds are generally much more gentle on the respiratory epithelial cells that they infect, and they don't lead to the cells dying as often. Whereas influenza viruses, they really do just kill the cells. They go in, they make thousands, tens of thousands of new influenza viruses, which then leave, and then the poor old cell has been destroyed by that, and what's left for it is just death. It dies. It can't survive the influenza virus infection. And when you have loads of dying cells, that is a massive trigger for inflammation. I mean, if you've got cells dying somewhere, that clearly shows you that something is very wrong. There is potentially a pathogen in there. We need the immune system to come in and deal with this. So dying cells is a massive trigger for inflammation. It's a massive trigger for the release of the inflammatory mediators. So that is why you get more inflammation in the respiratory tract when you get flu as compared to when you get a cold, and that is why you get more severe systemic symptoms in flu compared to a cold, because the systemic symptoms are not, they are not caused usually by the virus going into the blood. They are caused by the inflammatory mediators going into the blood. Flu viruses and cold viruses, they don't usually go into the blood, thankfully. They are not systemic infections. They give rise to systemic symptoms. They're local infections with systemic symptoms. And luckily, gastroenteritis is usually a local infection rather than a systemic infection as well. It just gives rise to systemic symptoms because of the inflammatory mediators going into the blood. Okay, so that's about the systemic symptoms of inflammation. Let's now actually talk about these two specific systemic symptoms of inflammation. So hopefully you've been thinking about my clue here. Muscle aches and tension type headaches, I'm about to link these together. So as a systemic symptom of inflammation, you can get your muscles in your arms and your legs hurting a lot. And you can also get a tension type headache. And I'm saying that tension type headaches arise in the frontalis muscles, the temporalis muscles, and the occipitalis muscles. So actually, these two things are the same process, potentially. Indeed, that's the theory that I'm about to give you, that these two things are indeed the same process. The inflammatory mediators go to muscles, and somehow they trigger pain in those muscles, and when those muscles are in the facial region, that's going to lead, the head region, that's going to lead to your tension type headache. So the question now becomes, how do these mediators, interleukin 1, TNF-alpha, and interleukin 6, produce pain in our muscles? Well, the answer is we believe they do it by triggering the production of prostaglandin E2. So let me just make a little flow diagram here. In fact, we'll do it over here. So, the way in which we believe this works, whoops, that's not what I want the pen, is we believe that these inflammatory mediators go to the muscle, and there we believe they produce a molecule, a very important molecule called prostaglandin E2, or PGE2 for short. So in full, this is prostaglandin E2. Now, this is a very, very important molecule. This activates nociceptors, and this is perfectly positioned because look, I've got a nice nociceptor here. Fantastic. I couldn't have planned that better. I didn't actually realise that that was going to be there, but that's perfect. So, prostaglandin E2 can activate nociceptors. This is the molecule that causes inflammatory pain. So I'll just write that key term down here. Inflammatory pain is the pain that you get in an area that is inflamed. So this is why when you've got a cold or the flu, you get a sore throat, because the area is inflamed because of the infection, and prostaglandin E2 is being produced at the site of inflammation and is activating nociceptors at that site of inflammation and therefore triggers pain, and that's called inflammatory pain. So prostaglandin E2 is one of the molecules that is usually produced at a site of inflammation. Indeed, in all of these local infections, prostaglandin E2 as well as these molecules will be produced in that tissue that is infected. However, we think that when these mediators, interleukin 1, TNF-alpha and interleukin 6, go into the blood, and they then can end up in tissues far, far away from the tissue that is actually inflamed and infected, that they can actually trigger the production of this same molecule, prostaglandin E2, in these muscle tissues that are far, far away from the actual site of infection. And that this can trigger pain in the same way that the prostaglandin E2 would trigger pain at the actual infected site by activating the nociceptors in that tissue and then causing the primary nociceptive afferents here, to fire action potentials, which I'll just abbreviate down to AP. Okay, so this is what we believe happens. So let me summarise it, because this is now the complete theory of how you get a tension type headache and indeed muscle aches in response to inflammation occurring somewhere very, very far away. So, when inflammation occurs somewhere in the body, so for instance in the respiratory tract in colds and the flu, or in the gastrointestinal tract when you've got a tummy bug, at that site, you'll be producing loads of inflammatory mediators. Some crucial ones that are going to go into the bloodstream are interleukin 1, tumor necrosis factor alpha, and interleukin 6. So when you've got inflammation going on somewhere in the body, you're going to end up with these molecules in the blood. The more inflammation you have, the more of these molecules will end up in the blood, the greater will be your systemic symptoms of inflammation, such as fever, malaise, fatigue, muscle aches, and a tension type headache. I'm not talking at the moment about how they cause fatigue or malaise or fevers. I'm just interested in muscle aches and tension type headaches, which we speculate are potentially the same mechanism. And this is what we think happens. These go to muscle tissues in the arms and the legs, and also the temporalis muscles, the occipitalis muscles, and the frontalis muscles, and there they trigger the production of this molecule, prostaglandin E2. Now, prostaglandin E2 is the mediator of inflammatory pain. It's a very, very important molecule. It's the major mediator of inflammatory pain. It will have actually been produced back at the site where the infection is, and it will be activating nociceptors locally to give rise to, for instance, sore throats and also tummy pains, if we're talking about a tummy bug. But we believe it can now be created in these far-off tissues by the presence of these inflammatory mediators that have gone to those far-off tissues. And then once you've got prostaglandin E2 produced in those muscle tissues, all it needs to then do is activate receptors on the nociceptors, and then that will trigger the primary nociceptive afferents to fire action potential after action potential after action potential after action potential until the prostaglandin E2 is broken down from that tissue. And of course, these stop being there and triggering more prostaglandin E2 to being produced. So until these go down and prostaglandin E2 synthesis stops, and once the prostaglandin E2 that was produced has been broken down, the nociceptor will continue to activate the primary nociceptive afferent, and that primary nociceptive afferent will now go into the trigeminal cervical complex. Its central process will go into the trigeminal cervical complex, and it will activate a second order nociceptive neuron, which I'll put on here. So remember, the second order nociceptive neurons are multipolar, so there's its dendrites, and here's its axon coming, and that will go up to the ventroposterior thalamic nucleus on the contralateral side, and that will deliver it, well, the third order neuron will then deliver it to the contralateral primary somatosensory cortex. Okay, so there you go. That is how we believe that when you get inflammation occurring in a far-off tissue, that it can lead to tension-type headaches and indeed muscle aches as systemic symptoms of the inflammation. So that's how having inflammation going on somewhere, we believe can actually give rise to a tension-type headache. The question now is, how can these other triggers, emotional stress, fasting, or sleep deprivation, how can they then lead to the activation of the nociceptors in the muscle tissue? Well, the answer is we don't know. However, we speculate that they may involve, that the mechanism by which they produce the activation of the nociceptors may also involve the production of prostaglandin E2. So at present, I'm afraid the best I can do for, as far as giving you a theory is concerned, is draw an arrow from these to prostaglandin E2. So somehow, being incredibly emotionally stressed or fasting or depriving yourself of sleep, these forms of physiological stress, somehow we believe that these trigger the activation of prostaglandin E2 in the frontalis, temporalis, and occipitalis muscles, just as the inflammatory mediators in the bloodstream would do, and that then activates the nociceptors in those tissues and therefore causes the tension-type headaches. But at present, we don't know is the reality about this. We speculate that they involve the production of prostaglandin E2. The reason for that is when we discuss drugs that are used to abort a tension-type headache, to get rid of a tension-type headache, the drugs that we know, that people use and which we know are effective, we speculate that they all work by stopping the production of prostaglandin E2. So that's why we think that prostaglandin E2 is probably very important in the pathophysiology of tension-type headaches. Okay, right. So that's all I can then tell you about the pathophysiology of tension-type headaches. I do, however, have a few more things to say. I want to talk about how you get accompanying nausea and vomiting with a tension-type headache. This is a very important topic because, indeed, all of the different types of headaches that we're going to discuss can have accompanying nausea and vomiting. And I then want to discuss where cutaneous allodynia comes from and also how the basis for this has something to do with how people can develop chronic tension-type headaches as well. So we do still have a few more things to discuss. So, nausea and vomiting. So, why, when you get a headache, do you also feel sick? And occasionally, if it's bad enough, can you actually be sick? So for this, we need to discuss the vomiting center and the chemoreceptor trigger zone. So I want to tell you a little bit about how vomiting works. So very important centers that we need to look at are the vomiting center and the chemoreceptor trigger zone. And these two structures are in the medulla. So I'm going to return back to this picture of the medulla. However, the picture of the medulla that we have got here is not actually the picture that I want. So I said earlier on when we were discussing cross-sections of the brainstem that we would later be drawing some more cross-sections, and here is now where we're going to be drawing another cross-section. This is the middle cross-section of the medulla going through at this sort of point, where you can still see the inferior olives, but you can also see the dorsal column nuclei. I want to now take a rostral cross-section of the medulla. I want to cut through here, and we will see the inferior cerebellar peduncles. We will not see a central canal anymore, and we will not see the dorsal column nuclei. We will just see the fourth ventricle behind now. And the reason I want to do that is that the chemoreceptor trigger zones are in a little area known as area postrema that is at that level of the medulla. So we need to be looking at the rostral medulla. So I'll try and keep the other one in sight as I draw this, and we'll draw it up here. So don't let me just draw the dorsal column nuclei. I must not draw the dorsal column nuclei. So let's put on the inferior cerebellar peduncles then. So here is which one's that one? The right inferior cerebellar peduncle. We're still imagining that we're looking from above. And then at the front we'll have the inferior olive still visible because we've gone up, so the inferior olive will still be visible. Here's the inferior olive on the other side. And then I'll come back here and try and make it symmetrical. There is the inferior cerebellar peduncle again. And over like that. It's not perfectly symmetrical, but it's good enough. Right. So let's now put on the structures that we recognise, just to make ourselves feel at home. So let's firstly put on the corticospinal tract. So here is the right corticospinal tract, here is the left corticospinal tract, so I'll just label those up. Those are the corticospinal tracts. Let's then put on the inferior olive, and I chose a very boring colour to do the inferior olive in previously, so we'll stick to that. So here is the inferior olive. Remember, we've just gone more rostral, so we won't lose sight of the inferior olive when we take cross sections. And there they are. Next, let's put on the medial lemnisci, and I think I'll do the medial lemnisci in a little bit more of an... Actually, no, we'll just stick to the colours that we've done it in previously, otherwise it will just get confusing. So here are the medial lemnisci, there's the right medial lemniscus, and here is the left medial lemniscus. Then let's put on our more fancy structures. So we learnt about the trigeminothalamic tracts, which are in these positions here. We learnt about the spinal trigeminal nucleus, so we can put that on. But before we put on the spinal trigeminal nucleus, let's put on the reticular formation. So let's have this colour here. So here is the reticular formation. We no longer have a central canal anymore. So this is all reticular formation here. We have new structures at the back there, which I'll colour in yellow. Those are something that I can actually label up fresh because we haven't seen those previously. So in yellow there, those are the inferior cerebellar peduncles that will be delivering information into the cerebellum. So inferior cerebellar, peduncles. And then behind, of course, instead of having a central canal, we'll now have the fourth ventricle sat behind the medulla up here. Alright, but all of that space at the back now is the reticular formation, so let me just label that up. I did it in this sort of bluey colour, faint bluey colour, so that's the reticular formation, medullary reticular formation. Now, what other structures do we have to put on? We no longer have the dorsal column nuclei, we no longer have the central canal, though all of that's ended now, but we still need to have the spinal nucleus of the trigeminal nerve and the spinal tract of the trigeminal nerve, and we want to put on the spinothalamic tract as well. So, fancy purple colour at the ready. Here is the spinal nucleus of the trigeminal nerve. White now. Here is the spinal tract of the trigeminal nerve in white there. And then aquamarine colour. Here is the spinothalamic tract still in this position here. Okay, and in fact this is a much simpler picture because we don't have the arcuate fibres there obscuring everything else. Right, so this is a rostral section of the medulla now. Why have we drawn this? Because I want to put on the area postrema, which is the chemoreceptor trigger zone, and I also want to tell you about the vomiting centre. So in red here, this area behind the reticular formation here, and if we go to this picture here, this area would be in this position that I'm putting on in red here. We've taken that sort of section across the medulla there, and we're now seeing these bits right at the back facing into the fourth ventricle behind the medullary reticular formation. If you like, they're the replacement of the dorsal column nuclei above the nucleus gracilis or gracile nuclei. Okay, so what is that structure that I put there? That is the chemoreceptor trigger zone, also called the area postrema. So it has two names. Area postrema is one of them, and then the other one is chemoreceptor trigger zone. Now, we don't actually need to know about this zone. I'm putting it on here to give you the full picture of how vomiting actually works. We did actually just need to know about the vomiting centre, but I put this here because it works very closely with the vomiting centre. This is the place that is involved in sampling the blood and looking for the presence of horrible molecules that indicate that we need to vomit. So think what the purpose of nausea and vomiting actually is. The purpose is to empty the stomach and the upper gastrointestinal tract, so the upper portion of the small intestine, if there is something horrible in there. So if you have eaten something that is very, very dangerous and which threatens your life, potentially is going to kill a lot of cells. So for instance, this is one of the things that commonly happens when people take anti-cancer chemotherapy, because the reality is that anti-cancer drugs are cytotoxins, most of them, they're poisons. So when they take the drug and it goes into the stomach and the duodenum, what will happen is it will then start to be absorbed into the bloodstream, and then when it goes in the bloodstream, this area, the area postrema, or the chemoreceptor trigger zone, it is looking at things in the bloodstream, and if it finds something that it thinks is dangerous, it will then activate and it will tell the vomiting center that we need to vomit to get this stuff that we're absorbing from the gastrointestinal tract out, because it's potentially very, very dangerous to the body. And the way that this area does that is that it doesn't have as good blood-brain barrier as other portions of the brain. So remember, if we're talking about microvasculature blood vessels in the brain, normally they are very, very tight. Usually very little can get out of blood vessels in the brain. So if we're looking at capillaries in the brain, they're very, very tight, much tighter than capillaries elsewhere, so that things cannot leave, molecules cannot leave capillaries in the brain unless they go through the endothelial cells, and the endothelial cells can then check everything that is going into the brain. And that concept is called the blood-brain barrier. So pen, or the BBB for short. So most of the brain has this structure called the blood-brain barrier, which is the concept that all of the capillaries and other microvasculature blood vessels in the brain are extremely tight, much tighter than normal microvasculature in other portions of the body. And this means that when molecules want to go into the tissue, they have to go through the endothelial cells, and if the endothelial cells don't think that a molecule should be going into the brain, they can stop that molecule going into the brain. They can pump it back into the blood. So this is the concept of the blood-brain barrier. Now, in the area postrema, the chemoreceptor trigger zone, the microvasculature vessels are not that tight. The blood-brain barrier is not very tight here, so that loads of molecules within the bloodstream, for instance, chemotherapy toxins, can then come out into this portion of the brain, and they will be detected by the area postrema, and it can then activate. Okay, so that's the area postrema, very, very important in the physiology of vomiting, which is why I wanted to tell you about it. The other key thing to know about is the vomiting center. Now, you might be expecting me to put another little blob on my picture for the vomiting center. I would love to be able to do that, but unfortunately I can't, because the vomiting center is not anatomically discrete. It's not a nice little blob in the brain. Instead, it's spaced out like a spider's web. All the cells that are part of this center are not in one little blob. They're spaced out, I'm afraid. And therefore, I can't put a little blob on my picture. What I can tell you is that the vomiting center is in the reticular formation, so it's in this bit, but of course there are loads of other centers in the reticular formation, not just the vomiting center, so it's not the case that the entire reticular formation is just the vomiting center. However, it is a collection of the cells of the reticular formation. And the vomiting center is the bit that, if it becomes activated, it actually activates all of the processes that are necessary for you to actually vomit. So the contraction of the stomach and duodenum and things like that. All of the actual maneuver of vomiting is activated by the vomiting center. So we're not going to go into the actual mechanics of how you vomit. All we need to know is that if the vomiting center becomes active, it can actually lead to vomiting. And it leads to, I'm debating now whether vomiting has a double T. Let me go back to where I wrote it previously to see what I wrote previously. Vomiting, yes, it does have a double T. Okay, so let me just correct up that second one that I've put there. So, pen, I can turn this into a T, vomiting. And of course, it can also cause nausea. So, nausea and vomiting. I'm still debating whether it's got a double T. I apologise if it's only got a single T. So when the vomiting centre is activated, it leads to you feeling sick, you feeling nauseous, and then you actually being sick. If it's activated enough, of course, it's differing levels of activation. The more it's activated, the more you go from being just nauseous to feeling, to actually chucking up. Right, so to complete up the little flow diagram then, the area postrema, or the chemoreceptor trigger zone, can activate the vomiting center, and then the vomiting center causes the nausea and the vomiting. So that's the way that vomiting normally works. The area postrema looks for horrible things in the bloodstream, and if it becomes aware that there are horrible toxins in the bloodstream, then it thinks that those have been absorbed through the gastrointestinal tract. We need to get whatever it is in the gastrointestinal tract out. We need to activate the vomiting center so that we actually chuck up. However, there are other ways for the vomiting center to be activated. The vomiting center can be activated when you are in a lot of pain, and this is the way that you can become nauseous and actually chuck up when you're suffering from a headache. So, when the cerebral cortexes are processing pain, by mechanisms that are unknown, by pathways that are unknown, they can actually send down signals that activate the vomiting center and therefore activate you to feel nauseous and to actually vomit. So when you are experiencing pain, when nociception is being activated, when you're experiencing the conscious sensation of pain, somehow the cerebral cortex has a pathway that connects it to the vomiting center in the reticular formation, and it can activate the vomiting center just like the chemoreceptor trigger zones can activate the vomiting center, and therefore it can activate feeling nauseous and actually vomiting. Okay, so that is all I'm going to explain to you about how you feel nauseous and can actually vomit when you're suffering from a headache. And that's why this is an accompanying symptom of all the different forms of headaches, because it's a general thing that can happen when you're experiencing a lot of pain that goes on and on and on. It can lead to the activation of the vomiting center, and then you feel nauseous and you actually vomit. Okay, so that's the explanation of that accompanying symptom. Last thing I want to explain is cutaneous allodynia, and in this explanation we will also understand how people can actually develop chronic tension type headaches. So cutaneous allodynia then, I'll just again remind you of what this actually means. This means that when you touch the area that usually hurts when you're having one of the tension type headaches, it can actually be painful to touch it, i.e. stimuli that should not cause pain can actually lead to pain because you so frequently do have pain in that region because you're having very frequent tension type headaches. The key to this mechanism is believed to be at the synapse between the primary nociceptive afferent and the secondary nociceptive neuron in the trigeminocervical complex. This synapse can strengthen, and this process of strengthening is known as sensitization. So sensitization is believed to underlie cutaneous allodynia. So sensitization. So let me explain this. When this primary nociceptive afferent fires an action potential, it will release neurotransmitter onto the second order neuron here, and then the second order neuron may fire an action potential. However, what you have to realise is that it's not the case that if this first order neuron fires a single action potential, that this one will then fire. So what I'm saying is, that if you got this one to fire one action potential, release one lot of neurotransmitter onto this second order neuron, it is very unlikely that the second order neuron would fire an action potential from that. That's not enough stimulation for it. To get it to actually fire an action potential and convey the signal up to the higher centres to actually give rise to the pain, this primary neuron needs to be firing action potentials at a much faster rate. So if it fires them at a fast enough rate, then what's going to happen? You'll be releasing neurotransmitter after neurotransmitter after neurotransmitter after neurotransmitter onto this second order neuron. Now granted, the neurotransmitter will continuously being removed and being reuptaken by the axon terminal here, but if you're firing frequent enough action potentials, then you won't have removed all the neurotransmitter from the synaptic cleft by the time that the next action potential comes along. So what will happen is the neurotransmitter will gradually be building up here. So you'll be getting higher and higher concentrations of neurotransmitter here, as long as you're firing frequent enough action potentials. Of course, if you're firing them with a gap of hours in between them, by the time you fire the next one, all the neurotransmitter will have been removed, but you're not. You'll be firing them much more frequently if you've got activation of this nociceptor. For instance, by prostaglandin E2, it will cause them to fire very, very frequently. Therefore, you will get the building up of neurotransmitter in the synaptic cleft, and that is a concept called temporal summation. So I'll just write this down here. So it's the summation of the neurotransmitter that is building up there because of the fact that you're firing action potentials so close together. So it's summation due to a time reason rather, hence why it's called temporal summation. And that will then cause this one to fire action potentials again very frequently, because of course you'll be having lots of neurotransmitter building up here, and that will cause it to fire action potential after action potential after action potential, etc. So my point here is that to get this second order neuron to fire an action potential, you need to have this first order neuron firing action potentials at a certain frequency. If you don't have them firing at a certain frequency, it won't cause this one to fire. Now, normally, when you touch your temporalis muscles, I'm doing it right now. If you touch your temporalis muscles, if you don't suffer from chronic tension type headaches and cutaneous allodynia, you do not feel pain there. And the reason is that you might be activating some of the nociceptors. You might be getting a few action potentials firing up the primary nociceptive afferents. However, those are not enough action potentials to actually get the second order neurons to fire at all. You won't be getting frequent enough action potentials to get the second order ones to fire at all, and therefore the message doesn't go any higher than the trigeminal cervical complex, and it doesn't give rise to the actual sensation of pain. So that's why normally you do not get pain when you just touch your temporalis muscles or your frontalis muscles or your occipitalis muscles. If you are suffering from chronic tension type headaches, then when you have every single one of the headaches, you will be getting the activation of this synapse, i.e. the primary neuron will succeed in activating action potentials in the second order neuron. You have probably, if you studied any neuroscience ever in your life, you will probably have heard of the catchy phrase, neurons that fire together, wire together, or long-term potentiation. All of these concepts, Hebbian plasticity is another name for it. This is the concept that when a synapse actually is successful, and what do I mean by a synapse being successful? I mean the first neuron actually successfully activates the second neuron. That's what I mean by this synapse being successful, that it actually causes the next neuron, the second neuron, to fire. When a synapse is successful, that synapse gets strengthened, it gets sensitized. The processes underlying this are not particularly well understood. It's speculated that what might happen is that the axon terminals might start releasing more neurotransmitter every time an action potential comes to the axon terminal. Alternatively, the dendrites could end up with a higher concentration of receptors for the neurotransmitter on them. Whatever the mechanism underlying it is, the synapse becomes stronger, and what can now happen is you can activate the second order neuron with fewer action potentials. So you might now be able to do it with less frequent action potentials. So you could activate this neuron to fire less frequent action potentials, and maybe this number of action potentials was too few to actually activate the second order neuron previously, i.e. in someone who didn't suffer from chronic tension type headache, that frequency of action potentials wouldn't result in enough temporal summation to get the second order neuron to fire an action potential. However, now that the synapse has been strengthened, now that it's been sensitized, that frequency of action potentials is enough to now activate the second order neuron, and that will then give rise to action potentials firing in the second order neuron, and therefore will result in pain. And this is how we believe that cutaneous allodynia works. You get sensitization of the synapses between the primary nociceptive afferents and the secondary nociceptive neurons in the trigeminocervical complex, which means now that it's easier to get that synapse to actually perform its function. And if you now touch the areas where you would get a tension type headache, you will activate the nociceptors, primary nociceptive afferents, to fire at a low frequency, but now this is high enough to actually activate the second order neuron and therefore will result in pain. That's what we believe underlies cutaneous allodynia, the sensitization of the synapse between the primary nociceptive afferent and the second order sensory neuron. Okay, right. So that's what we believe is the mechanism of cutaneous allodynia, and you have to have very frequent tension type headaches to actually get this strengthening of the synapse, this sensitization to occur. Now, unfortunately, this means that there is a bit of a vicious cycle with regards to developing chronic tension type headaches. If you are someone who suffers from very frequent episodic tension type headaches, then it can spiral down into chronic tension type headaches. So for instance, this generally happens in people who are very prone to emotional stress. So as I said right at the beginning, the world is full of a huge number of different people, and that's what makes it so interesting. Everyone is different, and different people have different emotional responses to things. Some people are very emotionally unreactive, and something terrible can happen to them and they'll have hardly at all, they'll have a tiny little emotional response to it, whereas some people are extremely emotionally reactive, and when that same event happens, they have a massive emotional response to it. They burst out in tears, they become really angry, or they get massive emotional stress. So in people who are very prone to emotional stress, people who are generally very emotionally reactive, you can get very frequent episodic tension type headaches. And when you're getting very frequent episodic tension type headaches, what can start to happen? You can start to get the sensitization of these synapses. And what does that now mean? That means now that firstly, your tension type headaches are going to become worse because now this is more effective, this synapse. You're going to, for any frequency of action potentials firing in the primary, you're going to now get a higher frequency of action potentials firing in the secondary. So firstly, your headaches are going to get worse, and secondly, you're going to now be more prone to getting them because maybe emotional responses that wouldn't have previously, or levels of emotional stress that wouldn't have previously been enough to quite cause a tension type headache, maybe they can now cause a tension type headache. Maybe they produced a certain amount of prostaglandin E2 production in the temporalis, frontalis, and occipitalis muscles that resulted in a frequency of action potentials firing up the primary nociceptive afferents that wasn't previously capable, i.e. it was too infrequent to actually activate the second order neuron. But now that we've got this sensitized, it means that that frequency of action potentials is enough to cause the second order neuron to fire action potentials. So what I'm saying here is that this sensitization mechanism, it's not just going to cause cutaneous allodynia, it's also going to mean that it's more easy to get a tension type headache, i.e. that levels of emotional stress that wouldn't have previously been enough to quite cause a tension type headache will now cause a tension type headache, and it is also going to mean that the tension type headaches that you previously got are now going to be going to be worse because now the second order neuron will fire a higher frequency of action potentials. So the strengthening of this synapse is not good at all, and it can result in a vicious spiral where the more tension type headaches you get, the more prone you become to actually getting them, and it just keeps reinforcing itself. And that's how people can end up suffering from chronic tension type headaches. Okay, so we will have a break here now. In the next video, we will discuss the treatment for tension type headaches. We'll discuss abortive treatment, which is NSAIDs and paracetamol, and then we'll discuss prophylactic treatment, which usually aims at reducing emotional stress because we only give prophylactic treatment to people who are suffering from either very frequent episodic tension type headaches or chronic tension type headaches, because these are the people who actually seek medical attention for the problem, and these are generally people who are suffering from a lot of emotional stress. So we try to treat the emotional stress with antidepressant medications. So we'll just have a bit of a revision of how antidepressant medications are believed to work through the monoamine hypothesis. So we'll do that in the next video, a bit of pharmacology coming up.